அதெல்லாம் எதுக்குடா தேங்க்ஸ்லாம். It's my duty.
I'm planning much
It's
more,
quite
sir.
topic actually.
Okay. I'm planning much more. உங்ககிட்ட வரேன் சொல்றேன்.
Okay.
Aditi, you are on live.
Yes, sir. Just start பண்ணட்டா, sir?
Over to you, Aditi. You just start.
Okay, sir. Good evening to one and all present here. Vaccines are the most cost-effective public health intervention we have, protecting not just individuals, but entire communities. This powerful reminder reflects the importance of immunization, awareness, and action in preventive healthcare. With this thought, I warmly welcome you all to today's insightful webinar, Session 2 of IndiVax 2026, Adult Special Population Immunization, which is part of the state-level vaccination webinar series organized by the Indian Medical Association, Medical Students Network, Tamil Nadu State Branch 2026 to 27, supported by the Indian Medical Association Junior Doctors Network, Tamil Nadu. Today's session promises to take us beyond routine childhood immunization and into the vital, often overlooked world of adult vaccination and immunization for special populations, an area that is central to comprehensive preventive healthcare. A good beginning sets the tone for a meaningful journey. To formally welcome our gathering and set the stage for today's session, I invite Isha Bhairavi, Academic Subcommittee Member, IMA-MSN TNSP, to deliver the welcome address.
Good evening, everyone. It gives me immense pleasure to welcome you all to IndiVax 26. I would like to begin by respectfully acknowledging the presence of our esteemed patrons, Dr. B. Sridhar sir, Dr. Sengutuvan sir, Dr. Ravikumar sir, Dr. Tyagarajan sir, Dr. Thiravyam Mohan sir, and Dr. Solomon Jaya sir. Their continued guidance and encouragement serve as a foundation for all our efforts. We're also privileged to have with us our respected state team, Dr. Annamalai sir, Dr. Jamuna Rani ma'am, Dr. Kannan Rajendran sir, Dr. Arunagiri G sir, Dr. Ajay Karthik sir, Dr. Balahariharan sir, and Dr. Hariram DJ sir, and also our organizing team whose dedication had made this even possible. IndiVax 26 is more than just a gathering. It represents a shared vision. A vision where knowledge meets purpose and where we, as future healthcare professionals, come together to understand and strengthen the role of immunization in protecting communities. We're truly fortunate to be joined by an exceptional panel of speakers today. Their expertise and experience promises to provide us with valuable perspectives and inspire meaningful discussions. As we come together for this event, it reflects our collective responsibility to promote awareness, improve accessibility, and contribute to advancements in vaccination and preventive health. I extend my heartfelt thanks to all our speakers, faculty members, organizers, and participants for being a part of this initiative. Once again, I warmly welcome you all. I hope this event proves to be insightful, engaging, and impactful for each one of us. Thank you.
Thank you, Isha, for that warm and gracious welcome. The right introduction is not just about credentials, but about connecting us to the mind behind the knowledge. To introduce our esteemed speaker for the day, I now invite Nitishri, Academic Subcommittee Member, IMA-MSN TNSP.
It is my privilege to introduce our esteemed speaker for today, Dr. Yogesh S. Sir. Sir is currently serving as a Senior Assistant Professor in the Institute of Internal Medicine at Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. With a strong academic foundation, he has completed his MD from Government Stanley Medical College and has been actively involved in medical education and clinical practice. He is not only a dedicated clinician, but also a passionate medical educator, recognized with multiple prestigious awards, including the Distinguished Academician Award and Best Researcher Award in 2024. His contributions to medical literature are remarkable, with over 17 international publications. Sir has presented his innovative work at both national and international platforms, including the Ottawa Conference in Melbourne, and has received several accolades for his research and teaching excellence. Beyond academics, he is deeply committed to student mentorship and advancing medical education through innovation. Today, we are honored to have him share his insights with us. Without further delay, I invite Dr. Yogesh S. Sir to deliver his talk.
Thank you for that wonderful introduction, Nityashri. Prevention is not just better than cure, it is the foundation of a healthier society. It is now my privilege to welcome our speaker, Dr. Yogesh S., MBBS MD Medicine, Senior Assistant Professor, Department of Medicine, Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. Sir, we are truly honored to have you with us this evening. The stage is now yours.
Yeah. Thank you, team, for your wonderful intro. And without much delay, I will start because even I have OP at 7:30 p.m. So I think I would complete by 7:15, right? Is it fine if I complete by 7:15, maybe 20 or 25 minutes?
Yes, sir.
Yes. Is my screen visible?
Yes, sir.
Okay, fine. So, good evening, all. And after a warm welcome and introduction, I am Dr. Yogesh, a senior consultant physician in the Institute of Internal Medicine, Madras Medical College, and Rajiv Gandhi Government General Hospital. So, today topic, whatever our IMA team has been given is the adult and special population immunization, the emerging clinical priority. So, this is extremely important and wonderful topic for all our budding physicians, clinicians, whatever, whoever, because everybody will be having at least one adult in their home and one geriatric population in their home, some pregnant female in the home. So, lot of adult priority immunization will be there in every individual houses, your relatives, friends, whatever. So this is quite a challenging and important topic. So I will make it in very nutshell. So this will be my broad coverage, immunological basis. Few important topics I'll highlight. Mainly the geriatric pregnancy, travelers, and finally the adverse effects and challenges. So who are the special populations to be considered? Can anyone or you can just unmute yourself and tell? Maybe 2 or 3 people can answer
Sir,
this.
patients
Special
with
population.
immunodeficiency disorders. Patients with
Immunodeficiency.
immunodeficiency disorder,
Yes.
pregnant and geriatric population,
Pregnancy, geriatric, excellent. Then
so splenectomy பண்ணிருக்க patients.
post-plenectomy. Okay. Anything?
The healthcare workers.
Whom?
Yeah, healthcare.
Healthcare workers. Very good. Who are we? Medical students, no? Medical students are something special population, right? So we deal with the lab, we deal with patients, lot of things, right? So even we are considered as one of the special population. So
And travelers, sir.
yes. So whoever is traveling from other countries, especially the endemic countries, so that we'll be seeing in the few slides. So basic process of immunization. It is an active or passive immunity against any infectious disease, and it is a type of immune response. Okay, without causing clinical diseases, but making it one of the most effective preventive strategies in the modern medicine. And we have so many types: active immunity, passive immunity, and then life course model. What you say is immunization across all age groups, not limited to the childhood stage. That is your life model. And the clinical references, the integral internal medicine, geriatric special population, whatever you have seen now. And the special adult immunization is now a core important part of internal medicine business, which shifts childhood only focus to life course immunization. So that is what the life course immunization model means. Okay, fine. What is this waning immunity? So immunity acquired in the childhood is over time and necessitates booster dose in adulthood to maintain the antibody titers. So simple example, what you want to give in waning immunity, which type of immunization in the childhood will be requiring a boost dose in the adulthood.
Tetanus, TD, அந்த மாதிரி.
Yes, TD vaccine. Then anything, especially geriatric above 60. Usually in all our channels they will tell, especially in summer season, they get all these reactivation diseases. What is that?
Tuberculosis, sir.
Shingles. They usually tell us shingles.
இது varicella.
போட்டுக்கோங்க அப்படின்னு. Yes. So zoster vaccine. So mainly all the adulthood, especially the geriatric age group, has to put the zoster booster doses. Everybody would have got at least once in their lifetime varicella infection. But when it comes to the adulthood, they have to put their antibody titers, and one shot of booster doses is required. This is just an example of this waning immunity. Second is new risk posture. So adult faces new risk, mainly due to the occupation, the lifestyle, the international travel. Now in 2020, 21, 22, we had this COVID, which required the target action beyond childhood schedules. And finally, we have the chronic diseases burden. For example, simple thing is we have the chronic kidney diseases or COPD, chronic obstructive pulmonary airway disease. So where lot of impression is going to make us more vulnerable to the vaccine preventable infections. Finally, why we need adult to be vaccinated is the community transmission. So it is very, very critical for the herd immunity to acquire. So why the adult immunization is very important. And if you see the burden of vaccine prevent diseases, you can see the influenza is the most common. You can see, especially the very recent. Second is the pneumococcal diseases, which is very, very, very highly fatal. Third comes our hepatitis B, especially healthcare providers, we, the medical students, lab professionals, whoever works in all the government quarters, hospitals, or medical colleges. And then comes the herpes zoster, and finally, so all these are vaccine preventable diseases. And if you see more than 65 years of age, you get this severe pneumonia or invasive infections due to pneumococcus, and influenza is going to affect the elderly immunocompromised patients. So if you see, herpes zoster is going to produce reactivation of latent varicella, and the QPPC it's more than 50. And pertussis again adult and pregnant women. So that is why all these vaccine preventable diseases have to be immunized probably for any adult. Okay. So basics of vaccination is just cells which is going to produce the antigen specific antibodies. The outcome is going to be the neutralization of pathogens. What we are going to do with our booster doses to enhance the secondary response, which is going to produce higher antibody affinity titer. So this is just an overview of immunological base of vaccination. And if you see the primary and secondary immune response, see all these primary responses which you are going to get for the first time vaccination in the childhood. So all these you would have studied in your pathology and microbiology. It is an IgM and the affinity is lower, the memory cells is generated. When we see the second dose of vaccination in adult, it is a rapid onset, the antititer is very, very high, it is going to be IG dependent, the duration is going to be or long lasting, memory cells are activated rapidly. So that is why booster doses exploit the second immune responses to achieve the more durable protection and the cornerstone of adult immune strategy. So you can see this graph. So this is the what is this? The secondary immune response, which is markedly fast, very, very strong due to the immunological memory. So that is why the adult booster immunization schedule is very, very important, right? And if we see the different types of vaccines, one is the live attenuated, activated, subunit, or recombinant vaccine. Can you give you attenuated vaccine we are going to give for us? Already some has been given, but just tell me, because our core topic is only adult immunization. So which live attenuated vaccine has to be given for adult in this?
Varicella, sir.
Varicella. So that is what I was telling you about a short while. Any conjugate vaccine, conjugate
Pneumococcal.
pneumococcal, excellent. For whom we put this meningococcal vaccine? Someone told at the
Sir,
starting there are some specials. Meningococcal,
splenectomy patients க்கு போடுவோமா sir?
postplectomy, and especially people who have some shunt surgeries which has happened previously. For example, if you have a VP shunt in the brain, VP shunt, you put this meningococcal vaccine. Okay. And finally, the toxoid. Toxoid is your tetanus and diphtheria. We don't call it as T. The TT has been, now it is only either TD or TDAP. Okay. So that is the important thing you have to get. Don't write any injection which is named as TT. It is now obsolete. And principles of adults we have already seen. Space vaccines recommended at defined age threshold. Second is occupation, travel, comorbidities. Third is immunocompromised patients require modified schedules. Critical for optimal immune responses. Continued from where it is left off. And do not restart the series. Multiple vaccines can be given at the same visit at different sites. Maintain accurate vaccination record for continuity of care. So, I will just ask you one small question. In the participants who are available online now, how many of you wanted to travel abroad for any of your exams? Just tell yes. How many of you wanted to write your maybe USMLE or UK exam or MRCP, FRCS? What you want? Because I cannot view whatever you know, I cannot view because my screen is not visible. Can you tell yes?
நான் போக மாட்டேன்.
No one? Everybody wanted to write only our NEET exam.
Yes, sir.
Sir, according to current situation, sir, US is so dramatic, sir.
Fine. You can go to Italy, you can go to Australia, whatever. So why such a question is, I have given so many young students with vaccine certificate. They tend to ask, are you vaccinated for those disease? You please give the proof of all the vaccination, whatever you have put in your childhood as well as before you leave to country. So that is important for this adult vaccination. Okay. So missed doses should always be continued, not restarted. This is a fundamental principle that prevents unnecessary delays in protection. So this three-step framework ensures every adult receives timely, appropriate, and well-documented immunization as a part of comprehensive preventive care. So you assess, you schedule, and you document. This is what I was talking about. Document. Keep it very safe. And it put it in your drive. Okay. This is very, very, very important for current scenario. Okay. So wherever you go, ask this vaccine certificate. So now I will talk about this 5 vaccines, and then we'll go into the specialty or subgroup population. Okay. So how we are going to go this influenza vaccine? It is only annual 0.5 ml intramuscular. How is Tdap or TD vaccine? Every 10 years, 0.5 ml IM. Or now we usually put like every 6 months once you put this TT vaccine wherever you get hurt. No, now it's only every 10 years, 0.5 ml intramuscular is your TD vaccine. Then comes your pneumococcal vaccine. Pneumococcal vaccine I will deal separately. Hepatitis B. All our medical, all our healthcare providers, we need to put 1 ml intramuscular 0, 1, and 6 months. And finally, now latest HPV vaccine. All the school going females, college going females, been started with HPV drive vaccine in Tamil Nadu. It is 0.5 ml intramuscular 0, 2, and 6 months. This zoster, it is 2 to 6 months, that is 0 and 2 to 6 months duration, 2 doses as booster dose. Pneumococcus. I already told is two type of vaccine. One is conjugate vaccine, the other is polysaccharide vaccine. So usually the protocol was given till last year. PCV vaccine will be given first 0.5 ml intramuscular, followed by PPSV 0.5 ml either intramuscular or subcutaneous, which will give the protection. Okay, the dose will be PCV first dose, PPSV 0.5 ml or subcutaneous or intramuscular more than 1 year after the first dose of PCV. So PCV is nothing but your pneumococcal conjugate vaccine. It is a conjugated vaccine. Second is pneumococcal polysaccharide vaccine. So PCV first, then followed by PPSV after 1 year. This is going to prevent all your invasive pneumococcal diseases, which includes meningitis, bacteremia, and pneumonia. Now, what has happened is we have PCV 20, which is only a single shot of vaccine going to give you lifelong immunity. This is the newest, latest trend of pneumococcal vaccination. It is PCV vaccine number 2020. You need not follow this first dose more than 1 year after PCV, nothing like that. You give one shot that is going to produce a lifelong immunity. So whoever is going to come under this category, please advise them to put the pneumococcal vaccine PCV 2020. Then why annual vaccination in influenza? So it is 0.5 ml every 1 year. Antigenic drift is the important thing you need to understand in influenza. So what it means, last year vaccine may not protect against this year's strain, and annual vaccine is non-negotiable. So that's why WHO reckons annual reformulation based on circulating strain. So the first year it will be H1N1. The second is half, that is 6 months later, the strain will be H3N2. And the next year it will be H5N1. So it keeps on mutating as the virus mutate seasonally. Every year you need to put the influenza vaccine 0.5 ml IM. Okay? And then comes the hepatitis B vaccine. You have dose 1, 2, 3. It is intramuscular route. You start with 0. The second dose first. The second dose 3 is 6 months. And anti-HBs titer should be more than 10 after vaccination confirms protection. Test recommended in high-risk individual. For example, you don't know when you have put this vaccine. You would have started maybe, or I think most of you now in year 5 years, like that. So sometimes you would have followed this schedule. Sometimes you missed. So whoever has missed, please put this anti-HBs titer, and only more than 10 after the vaccination confirms protection, you have to wait and then the vaccination. Otherwise, no need, just you wait, watch. Why this is important? Hepatitis B. It prevents and hepatocellular carcinoma, which is the long-term sequelae of chronic hepatitis B infection. Okay. And then comes the geriatric immunization. So, geriatric vaccination, you have the influenza, you have PC, you have the PSV, and the zoster vaccine. Okay. So, influenza is the same 0.5 IM annually. Pneumococcal, now it is PCV 20, so it is only a single shot. And then finally the zoster. Zoster is 0.5 ml intramuscular, 0 dose and 2 months, the second dose. 3 minute subunit vaccine over live vaccine. Okay, fine. So this is the GDEC vaccine doses and so who are the immunocompromised individuals? Name few immunocompromised individuals.
Post-splenectomy patients and patients with autoimmune diseases, pregnant women, and diabetic patients.
Yes, diabetes is the most common, no?
Yes, sir.
Rank பண்றது first diabetes. So diabetes, chronic kidney disease, chronic liver disease, COPD, your PLHA, patient living with HIV and AIDS, patient on dialysis, patient on chemotherapy drugs. Okay. Then comes your post-splenectomy, because post-splenectomy we don't do for everybody, but diabetes will be there for everybody, right? So
Yes.
that is it. So immunocompromised. Immunocompromised host are one is HIV or CD4 dependent disease, malignancy, transplant. That is very common nowadays. You see lot of transplant recipient patients are there. Either they would have done a renal or liver, whatever. So common. And then immunosuppressive drugs like steroids or any chemotherapeutic drugs. So increased susceptibility to impaired immune function, timely and appropriate vaccination, crucial and critical in these populations, right? Immunocompromised principle, the core principle, important thing is avoid live vaccine. The risk of vaccine strain, diseases in immunocompromised. For example, MR, varicella, live attenuated influenza, oral typhoid, all these are live vaccines. So please avoid live vaccines in the immunocompromised patients. Use only inactivated vaccine. It is safe across all immunocompromised states. Vaccinate before immunosuppression if possible. So if before you are going to start on any chemotherapeutic drugs or any biologicals, please vaccinate prior. And additional or booster doses may be required. That is, primary immune response may be suboptimal. So the final endpoint here in this slide is live vaccines are contraindicated in clearly immunocompromised patients. Okay. So what is the kind of advice I will give? Always verify immune test before administering any live vaccine. Okay. Hepatitis. Hepatitis has been given 6 months, and the dose will be immunocompromised patients may require double the dose, so 40 grams or additional doses. And the anti-HBs titer should be post-vaccination to confirm the seroprotection. Okay. Special population. So HIV specific vaccines, what are things you are going to put as vaccine? So inactivated vaccine has to be put. So you have to choose flu inactivated vaccine, HBV inactivated, and PCV inactivated vaccine. Live vaccines are all contraindicated. Yellow fever, again, it is a live vaccine contraindicated. And pneumococcal vaccine, PCV, PPSV, both are inactivated. So it is recommended for both. Vaccination and pregnancy. Another important thing. Many of your relatives, friends, they might be pregnant. And they will ask you, what are the important vaccines I need to put? So again, vaccines given during pregnancy protect both mother as well as baby. So it is a dual protection. And inactivated is live is again contraindicated. So examples like MMR, varicella, yellow fever, everything is contraindicated like immunodeficiency vaccine. Passive immunity transfer to the neonate is especially critical for protection against doses in the first weeks of life. So that is why we put the maternal vaccine with newer TD vaccine. Okay. So here you have the influenza inactivated vaccine, 0.5 ml IM, any trimester. Usually give like reason. So whichever season they come to hospital, it is going to be the winter season. We start immediately with influenza inactivated vaccine. Then comes the Tdap. So that is tetanus, diphtheria, pertussis. It is 0.5 ml IM, 27 to 36 weeks of gestation, and it provides the passive immunity to neonate against pertussis. The influenza vaccine is especially important in second and third trimester, where physiological changes increases the risk of severe respiratory illnesses. So you give either in the second or third trimester. Travelers vaccine. So what are the important travel vaccines, travel medicines, or recommendations that is required for any type of the travel, or at least the duration of stay for any individuals who is moving away or coming into our country? So first is destination analysis. You identify the region. You find out whether any endemic diseases is there. For example, yellow fever in sub-Saharan Africa and South America, Japanese encephalitis in Southeast Asia, and typhoid in South Asia. So these 3 or 4 important things has to be studied before you go there. Okay. Duration of stay. Longer stay increases cumulative exposure risk. So vaccines requiring multiple doses. For example, rabies pre-exposure must be initiated well before the departure. Third is exposure risk type. Adventural travel or rural areas, animal contact. For example, you may be dealing with some common animals like pigs or horses, and healthcare work abroad significantly elevate risk compared to the urban tourist travelers. And finally, vaccine administration. You please initiate vaccination at least 4 to 6 weeks before you depart from the specific area, so that the immune response completion of multiple dose schedules will be completed before you start. So important thing is hepatitis, 0 6 months, 2 doses, travel to endemic areas or contaminated food, water exposure, typhoid vaccine, yellow fever vaccine, and rabies exposure. Okay, I'll be talking about rabies separately. And then vaccination in chronic disease. So this is what I'm talking about. Diabetes, chronic kidney disease, chronic liver disease. All these things are going to impair your innate and adaptive immunity. So higher complication rates are going to be there, and therefore influenza and pneumococcal infections in diabetics and CKD carry significantly higher rates of hospitalization, ICU admission, and mortality. So the WHO and ACIP strongly recommend annual influenza and pneumococcal vaccine for all patients with chronic metabolic, renal, pulmonary, and hepatic conditions. So in your CRMA period, you are going to deal with all these type of patients: COPD patient, chronic renal disease patient, liver disease patient. Okay, and the most common is diabetes. Okay, diabetes is its own condition. So please ask to get vaccinated with annual influenza and PCV20, which is lifelong immunity. Chronic diseases vaccine, influenza for all the respiratory, diabetes, liver diseases, pneumococcal, especially for the COPD and our asplenia, post-splenectomy patients and CKD patients. Will you start dialysis for patients, diabetes, liver diseases, and hepatitis A for chronic liver disease specifically? Okay, so dialysis patient require a higher doses. This already we saw, and sequentially that PCV vaccine you give for all chronically ill patients. Then comes our healthcare provider, our healthcare workers. Face occupation exposures to all the vaccine preventable diseases daily, and vaccination protects both the healthcare workers and vulnerable patients from nosocomial transmission. So what are the important things to vaccine yourself? First is the hepatitis B vaccine. Then comes the influenza vaccine, MMR vaccine, 2 doses if you are non-immune. And finally, varicella vaccination, subcutaneous, 2 doses, that is 0 and 2 to 4 or 2 to 6 months. So, okay, this has been covered. Then comes the post-exposure prophylaxis. Post-exposure prophylaxis must be initiated immediately after exposure to be effective, and delay significantly reduces its own efficacy. And the two most critical PEP scenarios in clinical practice are rabies and hepatitis B. So this comes through animal life. What you're going to give rabies vaccine 1 IM 0 7 14 days. Immunoglobulin is necessary around the wound site and it is to be 20 internal units per kg. Timing, don't wait. Day 0 immediately. Thorough wound wash, soap, water for 15 minutes is the first step. This has to be advised for all the patients with animal bite. Then comes the needle stick injury, hepatitis. HBV vaccine 1 ml IM if unvaccinated. Or you want to give immunoglobulin based on the, suppose if she is a carrying pregnant woman, you want a passive immunity, so you give them immunoglobulin is 0.0 ml per kg IM, and it is ideally within 20 hours. And check the source of HBsAg status, check the recipient anti-HBs titer, and then you start with the final vaccination schedule. So rabies day 0, wound plus rabies vaccine plus is your immunoglobulin. Day 3, second dose of rabies vaccine. Day 7, third dose of rabies vaccine, and day 1 is fourth dose of rabies vaccine. Okay. So the time is critical. When do you give this vaccine and immunoglobulin both? Passive immunoglobulin provides immediate short-term protection, while the vaccination stimulates active term immunity. So both components are required for optimal post-exposure prophylaxis. Okay. So what are the important challenges and future directions? The current challenges in immunization are: number one, low awareness acceptance. Many adults unaware of recommended vaccine. Hesitancy remains importantly significant barrier to the coverage. Okay, this is very, 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 very important. Low awareness and acceptance. Second is healthcare system gaps. Lack of adult immunization programs, like what we follow, childhood immunization. We don't have commonly available in all the hospitals for adult immunization. So inadequate physician training and poor documentation system. The third thing I want to highlight, poor documentation system. You don't document the Tdap or ET vaccine. Simple example. Access and affordability, cost, availability, and cold chain logistics limit the vaccine access in low and middle income settings. And finally, special population complexity. We have a lot of immunocompromised patients, pregnancy, elderly patients who is going to require all the evidence-based approaches. So these are all very, very common challenges that we are going to follow for adult vaccination. What are the future directions? mRNA and next gen platforms for rapid development of mRNA vaccines, influenza, RSV. Till now, we don't have any vaccine for RSV and emerging pathogens, because RSV is the most common viral infection, especially if you see last November, December, January, RSV was the most commonly killing respiratory tract infection for both children as well as adults. So till now, we don't have any special vaccine for RSV. Digital immunization records. So national digital registries to track adult vaccine status and send reminders. Personalized immunization. So genomic and neurological profiling to tailor schedules to the individual needs. And finally, policy. We need a policy or advocacy by the government. So integration of vaccines into the national immunization program and health insurance coverages. Till now, we don't have the health coverages for adult vaccination. But for pediatric, we have the coverage in health insurance policies. So vaccination is not just a childhood intervention, it is a lifelong commitment to prevent health. Adult immunization must be elevated as a clinic priority in every internal medicine practices. You all young budding physicians, you may be a surgeon, you may be a gynecologist, whatever. But if you carry basic MBBS degree, you should be aware about all these adult immunization principles and their vaccine schedule thoroughly in order to at least put vaccine for your own family relatives. Okay. So I think I have come to an end. So the take home messages here is immunization is the cornerstone of preventive internal medicine. Adult and special population vaccine is growing priority in model health care delivery system. And routine immunization must extend beyond the childhood. Special population with tailored approaches and preventive care must be prioritized. So proactive immunization reduces disease burden, hospitalization, as well as the mortality, making it as a critical pillar of internal medicine practice. Okay, so these are all the references as in WHO CDC guidelines. Fine. Thank you all.
Thank you,
Thank
sir, for that incredibly enlightening session. Your insights have given us a much deeper understanding of adult immunization and the nuanced approaches needed for special populations. Curiosity is the spark that turns information to understanding. We will now move on to the doubts and discussion session. I request all participants to actively engage and clarify their queries. This is your opportunity to learn directly from an expert.
I think I made very short and crispy. I didn't go because I don't want to talk again theory. Whatever the basic things you require, that alone I have covered, right? Yeah, yeah.
சார் ஒரு டவுட் சார் ஆக்சுவலி பிரெக்னன்சில வந்து டிடாப் வந்து 27 weeks to 36 weeksக்குள்ள கொடுக்கணும்னு சொன்னீங்களா சார்? பட் ஆனா இப்ப இருக்கிற ஷெட்யூல்ல டிடி கொடுக்குறாங்களா சார் 4 weeks apart? அது கூட இது ஆட் ஆனா தரணுமா இல்ல இதை மட்டும் கொடுக்கணுமா சார்?
இல்ல இது ஆட் ஆன் தான். நான் ரொட்டீன் இம்யூனைசேஷன் போவே இல்ல.
எஸ் சார்.
ரொட்டீன் வந்து அது செப்பரேட். நீ சொல்றது டிடி வேக்சின் இட் இஸ் a part of your pregnancy vaccination schedule. அது சொல்றது.
எஸ் சார்.
இப்போ சப்போஸ் அந்த பிரெக்னன்ட் விமன் வந்து she may be a dialysis patient or she may be immunocompromised or any malignancy or she may be taking steroids for autoimmune condition. So for those people I'm talking.
Yes sir. Thank you sir.
Yeah.
Sir,
Any
another
other
doubt,
doubts?
sir.
Yeah, please.
Sir, regarding the HPV vaccination,
yes,
like in India, is it now available for males also, sir? Like, is it licensed or we should still wait for it?
you can, but still it is not compulsory for males. But what the government of Tamil Nadu has initiated is they have selected a few cities and they have started for young female who are going to complete their school as well as entering into college. They're going to give free HPV vaccine. The vaccine drive is still on. This is only I'm talking about Tamil Nadu.
Okay, sir. Thank you, sir.
But still, we don't have any protocol for male immunization. But maybe in upcoming days, no, the schedule will come because it's a very, very important vaccine.
Okay, sir. Thank you, sir.
Yeah. So any other doubts or anything to be clarified? How was the session? At least you can chat in the box. If you don't have any doubts, just give some replies. Arun Vandam. Okay, then. So if we have no doubts, Then convener, please take up.
Sir.
Now it's your turn. Yeah.
Yes, sir. Thank you so much for the session, sir. Over to Shruti.
Yeah, Aditi, we can conclude with the vote of thanks now. Please continue.
Okay, so thank you everyone for your enthusiastic participation. Gratitude turns a gathering into a meaningful memory. To express our sincere thanks, I now invite Shruti Ma'am, Academic Subcommittee Head, IMA-MSN TNSB, to deliver the vote of thanks.
Respected dignitaries, esteemed speaker, and dear participants, on behalf of the Indian Medical Association Medical Students Network and Junior Doctors Network, Tamil Nadu State Branch, I take immense pleasure in proposing the vote of thanks for today's insightful state-level vaccination webinar series, IndiVax 26, on the topic Adult and Special Population Immunization. First and foremost, I extend our heartfelt gratitude to our esteemed speaker, Dr. Yogesh Sir, for sharing his valuable knowledge, practical insights, and real world experiences. Your session has truly enriched our understanding and inspired us to explore immunization strategies more deeply. I would also like to express our sincere thanks to the esteemed patrons of IMA TNSB for your constant guidance, encouragement, and support in making this academic initiative possible. Our heartfelt gratitude goes to the state team, IMA-MSN TNSB, whose leadership and coordination ensured the smooth execution of this event. I would also like to acknowledge and thank Dr. Arunagiri sir, Dr. Bala Hariharan sir, Parthasarathi, Gokul, Vishal Manohar, Aditi, Nityashri, Isha, Jagrav, and Sri Nitin Raj for their tireless efforts behind the scenes in planning, coordination, and technical support. A big thank you to all the participants for your enthusiastic involvement and active engagement, which made this session truly lively and meaningful. Lastly, we remain grateful to IMA for providing such a platform that fosters learning, collaboration, and personal growth among students and young doctors. With this, we conclude today's session. Thank you all once again for your presence and support. Have a great day ahead.
Thank you, ma'am. With that, we come to the close of today's session, session 2 of IndiVax 2026. Every vaccine administered is a promise kept to the future. On behalf of IMA, MSN, TNSB, and the entire organizing team, thank you all for joining us this evening. We hope today's session inspires you to champion immunization in your communities and clinical practice. We look forward to seeing you in the upcoming sessions of the IndiVax 2026 series. Have a wonderful evening and stay safe.
Thank you all. Thank you.
Thank you, sir.
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 We request the participants to scan and give their feedback for the session too. The link will also be joined and sent in the groups respectively.